Welcome, welcome, welcome to tonight's WU University webinar, OCT Connect Case Presentations with Dr. Julie Rodman. I'm your host, Dr. Jennifer Stewart. So make sure you ask questions throughout. I know that the last time Dr. Rodman spoke and I had the pleasure of being the moderator, there were a ton of questions. So she might be able to see them, but she will be busy presenting. So make sure that you ask questions throughout. I will be back on to moderate at the end and we will get to as many questions as we can. But the easiest way to make sure your questions get answered is to ask throughout the presentation so we can make sure she gets to as many as possible. So without further ado, it is my great pleasure to introduce Dr. Julie Rodman. She's the chief of Broward Eye Care Institute in Fort Lauderdale, Florida, and a professor of optometry at Nova Southeastern University. She's also the instructor of record for posterior segment disease at the college. Her research interests include OCT, OCTA, and vitreoretinal disease. She's authored over 30 publications with an emphasis on retinal disease and recently published Optical Coherence Tomography Atlas, a case study approach, the first reference book on this topic written by an optometrist. She's a member of the AOA, AAO, FOA, and ORS, has been the recipient of numerous teaching awards, was recognized as a Primary Care Optometry News Top 300 Optometrist, and Newsweek's Best Optometrist of 2023. So Dr. Rodman, welcome back. We can't wait to hear the next OCT lecture. The last one was such a resounding success. So we are excited to hear you tonight.
Thank you, Dr. Stewart, and thank you to WU University for having me again. It's truly my pleasure to be here. This webinar was really created off of my Facebook page. So those of you that don't know, I have a Facebook page with one of my friends, Dr. Greg Caldwell, called OCT Connect. And the purpose of this Facebook page was really to allow my friends, my colleagues, my students, my residents to have an environment where they can ask questions about OCT in a non-threatening way. Where a lot of feedback, a lot of participation from people around the world, and it's been awesome. So when I put together this lecture, what I wanted to do was really think about cases that we rely a lot on OCT to make the diagnosis. So I'm going to go through some, we're not going to get through all of this tonight, but we'll go through some really fun cases where, like I said, OCT really was the game changer in helping to make the diagnosis. So let's start off with this 72-year-old Black male. He presented with decreased vision in both eyes at distance and near. His vision was 20/25 plus in the right, 20/25 plus in the left. You can see his medical history. He was HIV positive with a CD4 count of 336. His viral load was 46. So you can see that these numbers are pretty bad. This guy's not in very good shape. He had high cholesterol, high blood pressure, and he was a type 2 diabetic with poor blood sugar control. So this sounds typical of what I see on a day-to-day basis in the clinic in downtown Fort Lauderdale. So it was an open bag here as to what I was going to find on his retina. So here's kind of I don't know what you want to say. It's not really a montage, but 3 images that I cropped to really highlight what the abnormalities that I was seeing clinically were. So let's start off with this middle picture because I think this is probably the best representation of this anomaly. So here's his optic nerve. Up here, there was this big orange elevated lesion with some surrounding what I like to call little satellite lesions. And then there was another one over here, and you can appreciate the elevation because you can see that these blood vessels are coursing up and over these lesions. So number one, I knew that they looked deep because these blood vessels are coursing over them. But God, I didn't know when I first looked at it what the heck I was dealing with. You can see on this picture on the bottom left, there almost looked like there was a resolved dark hemorrhage. And what I like to tell the students in class is that the darker the hemorrhage, the deeper it is in, let's say, retina choroid. So this one looks almost like a maroonish color, which makes me think it's subretinal or maybe even at the level of the RPE. And you can see that adjacent to it, it looks like there's almost like an old scar there. So there's something making me think, okay, there's new stuff, there's old stuff, and then all these lesions, and then up here, another bleed, which looks, again, very almost greenish. So lots of stuff going on. So at this point, I'm going to be honest, I really didn't know what I was dealing with, but I thought it looked almost like a cancer. I'm like, is this a malignancy? What does this patient have? So of course I go to my trusted OCT because for me, that's the way that I solidify or make a diagnosis in situations where I'm really not very sure of what's going on. This is the left eye. Left eye didn't look quite as bad. There were quite a few areas that looked like there had been some resolved, problems, some resolved retinal problem. You can see here some pigmentation again here. So not as demonstrative as the other eye. And here's the OCT. So I'm going to spend, this is an OCT lecture, my favorite thing to do. So I'm going to spend a bit of time talking about what we see on these OCTs here. So on this top OCT, find the RPE. Okay, that's always, I find, the easiest way to dissect through a more difficult or challenging OCT. So if you find the RPE, which is this hyper reflective band, and you kind of trace it up and over, you can see that the RPE is lifted up. So the first thing we notice here is that this is a massive area where the RPE has been lifted up. So if you remember, if you were on my first webinar that we did probably last year, I said anything that lifts up the RPE is essentially called an RPE detachment. So we're dealing with a massive RPE detachment here. But we're not done. When we say RPE detachment, we have to then ask ourselves, what kind of RPE detachment is it? Remember, there's multiple kinds. There's a serous pigment epithelial detachment, which would look black. Okay, it would have all one homogeneous black color to it. So you can rule that out because you can see that on the top of this PED, there's some haziness to it. The second kind of PED is a drusenoid PED, which is going to look really white inside. This one doesn't look white. And then you have another one where you have what we call hemorrhagic or fibrovascular, where you have some blood in it and you have some serous fluid in it. So this, if anything, simulates a fibrovascular or hemorrhagic PED because there's multiple colors in it, right? We have this kind of white hazy part, and then we have the darker part underneath it. So I'm thinking that this is a massive PED that definitely has different components in it, blood and probably some serous fluid. The other problem here also is that you can see that if you look at the neurosensory retina or whatever is left of it, you can see that there's some darker spots within. And remember that dark on OCT usually indicates serous fluid. There should never be serous fluid just hanging out in the neurosensory retina for no reason. And you can see it on the other side as well. So lots going on here, but there's definitely a PED and there's definitely some leakage or something probably coming up from the outer layers of the retina because of this massive PED. So we've established now that this is a pigment epithelial detachment. And if you, I don't know if you can see it, I have an arrow here coursing through the second lesion. And the second lesion, if we do the same kind of thought process, we find our RPE, we trace it over, we hit some bumps in the road here. These little bumps in the road are these tiny little spots, and those are drusen, okay? And then if you keep coursing over it, we come to another PED, okay? And this PED looks a little more black in coloration. So this one's possibly serous. And then above it, we have what looks like another little detachment of some sort. This is a neurosensory detachment, a separation of the neurosensory retina from the underlying RPE. So a lot of fluid, a lot of layers involved. But what's the diagnosis, right? So what would cause an abnormality that would present in this fashion? Here's some more cuts, just some really wild things. Here we have what we call a bilobed PED. This one again has, you can see the variability in the coloration. There's some black and some more haziness. Same thing here, a lot of variability. And then look over here at this hyperreflective wedge. That really doesn't belong there either. Hyperreflective wedge may indicate that there's some bleeding. And another cut where there's 1, 2, 3, 4, at least 4 pigment epithelial detachments altogether. And then down here, another very interesting appearance where you have the RP is again lifted up, and there's a lot of different colorations in here, some hyper reflective areas that are probably bleeding, and again, some darker areas that are probably serous fluid. And then look at this schisis cavity here. Schisis meaning a separation of our neurosensory retina with these kind of pillars. So man, these OCTs are loaded, right? There's lots of stuff going on. Kind of ruled out what I had initially thought, that there was maybe a melanoma or some type of malignancy, because this is certainly pigment epithelial detachments. So it helped me, let's say it helped me rule out the really, really bad, but it was an anomaly that, what kind of disorder could cause these OCTs. So this patient had what we call polypoidal choroidal vasculopathy, which is a mouthful. It is a type of neovascularization, or it's a disorder where you get neovascularization or choroidal neovascular bleeding. And it's also been called a peculiar hemorrhagic detachment of the RP and choroid. So if you kind of think about what all these words mean, it's a hemorrhagic detachment. So before I was saying that the pigment epithelial detachments had blood in them and they had serous fluid. So that's the hemorrhagic detachment, and it's of the RP and the underlying tissue. They're suspected when you see these orange polyp-like lesions, thus the word polypoidal. And the interesting thing about polypoidal is that unlike regular choroidal and neovascular membranes, they can happen anywhere in the retina. They can happen near the nerve, in the macula, in the periphery, in the mid-periphery, the equator. So anywhere in the retina, you can see these lesions. And the nature of them is that these PEDs will come up and then they'll resolve. And then they'll come up in a different location and they'll resolve. So if you think about the pictures I showed at the very beginning, I showed you that there were varying stages or degrees of this presentation. There were some resolved lesions, some bleeding, some resolved lesions. That's the nature of what this disease does. It kind of comes and goes and comes and goes. And usually patients don't know that they have it until the macula is affected. And so when we see patients with these large PEDs or choroidal bleeding or subretinal bleeding, in African-American patients, we tend to kind of think along the lines, maybe that's polypoidal and not your regular AMD. So the pathophysiology is actually very interesting. So this is it's a good kind of schematic of the lower part of the retina and choroid. So down here we have our choroid, and we know that the choroid is really what's responsible for providing blood and nutrition to the eye. Within the choroid, we have what we call BVN. BVN stands for branching vascular networks. So these little kind of spaghetti-like lines here are the vessels that are running through the choroid. Normally, those blood vessels should just look like spaghetti. In polypoidal, at the terminal end of each vessel, there's these polyps or these bulbs. These polyps shouldn't be there. When I teach this, I like to say it's like spaghetti and meatballs, okay? Because these polyps are like meatballs living within the spaghetti, and they should not be there. So if you think about these polyps living within the choroidal space, what's going to happen is they lift up, they push up the RPE, and that's the pigment epithelial detachment. Those little polyps are like marbles pushing up on the overlying RPE. And that's why this condition is called polypoidal choroidal vasculopathy, because the polyps are originating in the choroid and they're emerging up into that RPE space. What can happen over time is that because these polyps are made up of blood, they can break, right? Anytime you have an area where there's blood where it should not be, they can break. And if they break, you're going to end up getting a choroidal neovascular membrane. So that's kind of the pathophysiology behind this disorder. If you break down the word of really how we categorize this, it's called a serosanguinous RPE detachment, which is really the same as a hemorrhagic or fibrovascular RPE detachment. The word sero stands for the serous part. And in French, sanguine means blood. So serosanguinous is the sero/blood component of these pigment epithelial detachments. Here's a really nice example. Once again, the yellow arrow is pointing to the PED. And what I want you to appreciate is the variability and the reflectivity. The haziness is the blood, and the black part is the serous fluid. Think about, once again, this PED collapsing or breaking over time. leading to this area here, which is the choroidal neovascular membrane. So as that RP or the RP detachment breaks and settles, it's going to lead to a CNV. And this black area is fluid, again, because there is a choroidal neovascular membrane there. The best way to diagnose this condition is actually with indocyanine green because it's a choroidal disorder. When you have something living in the choroidal space, the best way to image it is with ICG, which tends to get better penetration into the choroidal space. And what you're going to see are these polyps. These are beautiful polyps here in each of these images, different images, FA, ICG, and this is OCTA. So different images of these polyps. We also call the choroidal neovascular membrane a double layer sign, really just because it looks like the RPE is duplicated upon itself. This over here is the serosanguinous RPE detachment. Once again, the hazy area is the blood, the black is the serous fluid, and here is your collapsed area that has turned into a choroidal neovascular membrane. Also, once again, double layer because here's your first kind of layer of RP. And really, this is Brooks membrane, but when you look at it, it looks almost sandwiched upon each other. So it's called a double layer sign. So finally, to tie up this case, how do we make the diagnosis? We look for specific things. We look for sharp, multiple PEDs. So I showed you on our patient, there were situations where he had 4 of them lined up together. So when you see multiple PEDs, think about this condition. When you see massive PEDs, I mean, this is massive, think about this condition. And if you see PEDs with a collapsed area next to it, simulating a choroidal neovascular membrane or a double layer sign, think about polypoidal. And just to show you one more time, our patient, you can now appreciate these are the polyps. These are the serosanguinous RPE detachments made up of different reflectivity throughout the PED and the other cuts. So here, that's a really a good case of how, if you're familiar with this disorder, how the OCTs helped us to make the diagnosis. Okay, let's move on to the next case. This is a 13-year-old Black female who came in for her first eye exam ever. She never had any visual problems, but her mom reported that she felt like her daughter was just not seeing right. Her visual acuity was 20/30 in the right, 20/30 in the left. She failed the color vision plates. And it's interesting because she said to me initially, oh, I don't have any problems. But then upon further questioning, she said, yeah, I really can't see the blackboard very well at school and my grades are sinking. So that was her history. And this was the clinical presentation. So I kind of magnified on top here what was of clinical importance on fundus exam. So hopefully you can appreciate that this patient has what looks like a bullseye maculopathy. So essentially there's a depigmented area surrounding the fovea, and it really highlighted very nicely on the photographs. The white part is really just an increased light reflex, if you want to say, or sheen of the ILM in a very healthy young patient. So some of the things that you should think about if you see this type of appearance in a younger individual. Stargardts. I mean, Stargardts, we get a beaten bronze kind of look in the macula with sometimes pisciform flecks. So this wasn't perfect for Stargardts, but something to think about. Cone dystrophy, definitely. Cone dystrophy is high on the list because it presents with a bullseye maculopathy, and patients are going to have no color vision because their cones are affected. Chloroquine or hydroxychloroquine toxicity, which we know is Plaquenil. This patient was not on Plaquenil and certainly, not the best diagnosis. RP, not really a great diagnosis either, but sometimes if you have reverse RP, the macula can look this way and the rest of the eye looks actually decent. But none of these except for cone were really that appropriate. So let's keep moving on and I'll show you what we came up with. So here's her OCTs. I have on the right-hand side here what a normal OCT should look like, really, because I wanted to highlight that the neurosensory retina should have a nice thick appearance, especially in that macular foveal area, I should say. In this patient's eyes, this is her right eye, the neurosensory retina looks excellent over here and over here. But look at what happens at the fovea. You can appreciate that the neurosensory retina is very, very attenuated. There's a very small wedge kind of left in the center there. And look at what's happening with all of the outer retinal layers. So the first one is your photoreceptor integrity line. It is completely missing. from here to here, you can see there are some little specks of hyperreflectivity left there, which means there's some dead photoreceptors. The RPE actually looks okay, but we have honestly a complete loss here of the photoreceptors. That's why this patient could not or did not have any color vision. In the left eye, it had a similar appearance. You can see that the neurosensory retina is very attenuated. There's only a few little pieces left there. And again, the photoreceptors are missing from here to here. So this correlates with that bullseye maculopathy appearance that she was presenting with. But the question is this cone dystrophy? What is the diagnosis? Here's some images of the OCT, just to show you that it goes along with the bullseye appearance. This navy means that it's thin, right? So this is a thickness map on a micron scale showing where the darker colors mean thinner. You can see here 102 at the fovea is extremely thin, 112, very, very thin, surrounded by kind of more normal numbers, but very, very thinned out foveas. Fundus autofluorescence also highlights this bullseye appearance. Remember that when you have loss of tissue, you're going to see black, hypo, dark. So you can see in the center here, that goes along with that OCT appearance where there was attenuation. And the left eye similarly. We also got multifocal ERG on this patient, and I'm not huge into electrodiagnostics, but the blue on the bottom is the normal. You can see the peaking of the cones. They're supposed to have these little kind of sawtooth, if you want to say, little projections all the way around. Our patient, you can see in the center here, which correlates with that abnormality centrally at the fovea, you can see how the peaks are very, very dull. They're not spiking up. They're not normal. As you get around the fovea, they start to become more normal. So definitely decrease centrally there as well. And just a different representation. So just a lot of things showing us this bullseye maculopathy in different formats. So we said, we're going to send this patient out for some genetic testing, because instead of just saying, oh, you have cone dystrophy, which she certainly looked like she had, we wanted to confirm. So we used a saliva test. You can do it in the clinic. It's actually not very enticing to use. You have a patient spit into a test tube, and then we send the test tube into the company, and they run a lot of genetic testing for us and send us back a report. So they sent us back this report, and it turns out this patient had something called an EYS variant, or that was the pathogenic variant that they found. And what does that mean to me? It doesn't mean a whole lot. But if you read the line on top here, it says one pathogenic variant was identified, the EYS, which is associated with autosomal recessive RP. And I'm thinking, this is odd. Her fundus appearance certainly does not simulate retinitis pigmentosa at all. So you go on to the next page of the report, and there's a couple of things that were identified, but nothing that really said, okay, this is what I thought I was looking at. But that's not all. Before I get to the diagnosis, her twin sister is in the room next door, and she comes in for an eye exam also. And these are her fundus images. So it's going to look familiar, because she also has a bullseye maculopathy, not as significant as her sister's, but certainly there's something going on in both eyes as well here. Her OCT also doesn't look great. Her vision was better because she had a little area right here. You can see this hyper reflective area here, which is some leftover. There are some cones and kind of hanging on for dear life there. So you can see that there is a loss from here to here and here to here. And that's that kind of hypopigmented area that correlates with the bullseye maculopathy. And even in this eye, she has a little remnant of tissue. So not as advanced as her sister, but certainly looks very similar to the sister's presentation. And here's the left eye. Same exact appearance on the thickness map. Same on autofluorescence. Kind of strange. Almost looks like exact same thing as the sister. Multifocal ERG, the same. Guess what? Also did genetic testing on this patient, and this sister had the exact same variant, the EYS gene. So went and did a bunch of research, because I'm thinking, now this makes no sense. I don't think this patient has retinitis pigmentosa. It doesn't make sense. But just to point out one thing, if you notice this word heterozygous, this is actually really important, because if it's heterozygous or homozygous, actually affects or changes the diagnosis. So if you read kind of the summary point on top there, EYS mutations are very common causes of autosomal recessive RP. But if the patient has heterozygous EYS mutations, that is more consistent with just generalized macular disorders or generalized macular dystrophies. So it wasn't diagnosed that she had a cone dystrophy. It wasn't diagnosed that she had any specific dystrophy except a generalized quote unquote macular dystrophy. So we're watching her. It was an interesting case because I thought that the diagnosis was odd and off, but it made us think specifically in young children or in, I want to say adolescents, what the differential diagnosis might be if you see a bullseye maculopathy. So more to come on that patient. And these are just some I found fascinating. If you look at the twin side by side, twin number 1 has a really well demarcated bullseye appearance, and there's twin 2, the other eye, OCTs. I just thought it was so cool that they're sitting in the rooms next to each other and looked almost identical. Okay, let's move on to this case. I think this is probably going to be the last one that we get to. We'll see. So this is a 70-year-old Caucasian female who came in with, pretty good vision, 20/30 in the right, 20/20 in the left. She says, I have started to see waviness of surfaces while using my home Amsler grid. I do take an ARED supplement because I've been told that I have macular degeneration. Okay. So I take a look at her fundus, these images, I take a look at her clinically, and I'm thinking to myself, this doesn't really look like macular degeneration. And, there's many times that we all get patients in the clinic that have previous diagnoses and maybe we question them. So we use multimodal imaging. We use our diagnostic skills to make better diagnoses. But I'm like, okay, let me give this lady the benefit of the doubt. Let's take a look at some other testing and kind of go from there. So let me actually go back for a minute to point out a couple of things, and then we'll go into what this is, as you already saw. So you can see that this patient had some hyperpigmented areas, or what I like to call pigment plaques in each eye. She had also some of these lighter areas, some kind of glistening in the macular area. If you look extremely closely, though, and I would say this is one of the hardest diagnoses to make clinically without having some of these more kind of obvious features, she's got these vessels that I like to say are diving in on the temporal side. So this vessel here and this vessel here. So I know you already saw the next slide, but if you have kind of a thought of what I'm going to hear, when you hear the term right-angled venules or diving blood vessels temporally, this correlates with something called macular telangiectasia. And I'll tell you that macular telangiectasia is oftentimes misdiagnosed as AMD because patients can get pigment plaques in AMD, and they can get kind of these lighter areas that people think or diagnosticians think is drusen. So we have to be careful why this case is in this presentation, is because OCT is going to be the diagnostic modality that's going to tell us that it's not actually AMD, but MacTel. So to kind of give you a really quick synopsis of macular telangiectasia, this is an abnormality that originates in the neurosensory retina. So when you look at your anatomy here, we're not going to go through all the detail, but I circled this box around Mueller cells because this actually is an abnormality of the Mueller cells that live in the neurosensory retina. So the Mueller cells are actually what helps to keep our blood vessels and all the contents of the neurosensory retina intact. It provides structural integrity to the blood vessels. So if we have a breakdown or a problem with our Mueller cells, we're going to have a problem with the functionality or the integrity of the retinal vasculature. And that's really how this disorder originates. So looking at this picture here, instead of kind of memorizing, up here we have our Mueller cells. If the Mueller cells become sick or degenerative, our blood vessels are not going to work properly. So what happens here is if this part of the neurosensory retina is not functioning properly, the layers underneath are not going to get fed properly. That's going to lead to photoreceptor death. It's going to lead to death of the RP and underlying areas, allowing for blood vessels to come up from the sub-RPE space up through the RPE into the neurosensory retina. So just to kind of reiterate, Mueller cell dysfunction leads to dysfunction of kind of the posterior structures of the retina and choroid. This leads to death of the photoreceptors, RPE, Brooks membrane, choroid, allowing for blood vessels to break through the blood retinal barrier up into the neurosensory retina. We get pigment plaquing in this disorder because the RPE is dying, it's atrophying. When you have atrophy of the RPE, you're going to have migration or pieces of pigment that are going to migrate up into the neurosensory retina. So each stage of macular telangiectasia essentially correlates with what's happening at this kind of anatomical level. So this is not a disorder that starts down in the choroid like polypoidal. This is a disorder that originates in the neurosensory retina. And the OCT actually goes along very nicely with each of these stages. So if you look here at OCT, this is, normal OCT. Everybody knows this. These are all these layers are intact. And what I essentially have here is the two parts of the OCT that are going to be affected early on in the disease. Because remember, Mueller cells live in the neurosensory retina. So the neurosensory retina essentially is the red line down to the green line. So somewhere within this section or this section is where this disease is going to originate. So this is normal. In macular telangiectasia, remember that the Mueller cells are degenerating or not healthy. So what begins to happen is that the blood vessels, again, lose their integrity. What does that mean? It means that you're going to have leakage out of these fragile blood vessels. Remember that leakage on OCT is black. Serous fluid is black. Mueller cells live high up in the neurosensory retina. So the first thing you're going to see is these black hyporeflective spaces, which indicate that there has been some breakdown in the integrity of the Mueller cells. We call this an ILM or inner limiting membrane drape because the most superficial layer of the retina is the inner limiting membrane, and the fluid or these cystic spaces are going to live right underneath the inner limiting membrane. So this is classic for macular telangiectasia. Sometimes it's challenging if the patient has diabetic macular edema, because then you look at this and you're like, well, how do I know that these changes are not from another entity? And that's more difficult. But in a patient that doesn't have another conflicting or coinciding diagnosis, when you see this, what we call, quote, ILM drape, that should make you think of macular telangiectasia. As the disease progresses, you're going to see that this cavitation becomes greater or larger because the Mueller cells or the vascular integrity is going to continue to disintegrate. Over time, these cavitations are going to spread further and further into the lower parts of the retina. And this goes along with this picture that I showed you here. We're starting off very superficially, and the problem is going to begin to affect the photoreceptors south. So that's what you should be thinking of. We start off with a very superficial abnormality, and over time, the integrity of the lower retinal anatomy and under and even below it is going to become affected. You can even see, if you look very closely here, that there is a darker area right here, right at the photoreceptor integrity line at the fovea, because remember I told you that the photoreceptors are going to become affected if the Mueller cells aren't working properly. Notice now how we have a cavitation in the neurosensory retina, and we have involvement at the level of the photoreceptors. What do you think is going to happen if these two kind of fuse or merge? You're going to get almost what looks like a macular hole formation. You have fusing of this superficial cystic space and the lower cystic space that happened at the photoreceptor integrity line. Now the RPE is not working because we're losing that connection between the blood retinal barrier. And that's why you see these hyperreflective spots, which is RPE hyperplasia or pigment plaquing. So it all makes sense if you think about it from the pathophysiology standpoint instead of memorizing it. And if you do get eventual connection between these cystic spaces, you can actually get a macular hole. This over here is pigment plaquing, hyperreflectivity. And the last stage of it is if you end up getting choroidal neovascularization. If you go back to our patient here, I talked about this funky vessel. Okay, that's the abnormal vessel that's going to be affected by the degradation of the Mueller cells. Here you can see the RP pigment plaquing, and you can see some glistening, really just an indication that there is some abnormality in this area here. If you look at this patient's OCT, this was when we started, when we started was that ILM drape. This was the kind of involvement of the photoreceptors in the outer retina. This here is pigment plaquing. Okay, so this correlates with this OCT scan. And if you looked at this and you thought it was AMD, hopefully when you did the OCT scan, you could appreciate that this appearance does not go along with what macular degeneration would look like. It actually is pretty pathognomonic for MacTel. The other eye, same thing. This patient also had vitreomacular traction in this eye as well. I'm sorry, I don't know why this keeps coming up. But you can see these intraretinal cystic spaces here with the ILM drape right over it, a very superficial line of ILM. This hyperreflectivity is the pigment plaquing. You can see the breakdown of the photoreceptors here, the loss of the photoreceptors all here. And this is the pigment migration. And I wanted to show you another one that wasn't so obvious. You know, this is another patient. I'm telling you that they had macular telangiectasia. When you look at the picture here, you know, these temporal blood vessels really, maybe they look a little strange, but I'm going to be honest with you. You know, I would look at this initially and it doesn't look like anything is yelling out at me. I mean, perhaps if you're a really good observer, but it's not like the other patient where there was pigment plaquing and a lot of obvious things going on. So I look at the OCT. I believe this patient, I didn't put the vision here, but I believe the vision was slightly reduced, which is the whole reason that we went ahead and did OCT. You can see here that I don't see an ILM drape. If I had kind of gone through the scans and put a bunch of them on here, perhaps it would have picked up on that. But what you would notice is some of the loss of the photoreceptors here. So this eye is a little bit more difficult because we're kind of not seeing that first stage, but the left eye gave it away. Because here's my ILM drape. You can see the thin ILM and the cystic spaces, and probably a little bit of involvement of the outer retina as well. So this one wasn't so obvious because in fact, this patient even had drusen, but these OCTs gave it away that this patient had macular telangiectasia. Just to share with you on angiography, macular telangiectasia has a very clinically, again, diagnostic appearance. So if you look at this scan, and we're not going to spend a ton of time going through OCT angiography, but here's your ILM drape. Here's involvement of your photoreceptors down here. You can see it here as well. But if you look at the OCT angiography, which is really an en face cut, so it's more of a horizontal cut through the vascular structures, we're looking here at the most superficial vascular layer. You can see here that these blood vessels, especially in the area here temporally that's abnormal, you can see how they almost look like they're dragged and kind of distorting the contour of the foveolae vascular zones. I wanted to share that just because macular telangiectasia does have a very characteristic appearance on OCTA because remember, it's a blood vessel disorder. So when you look at the blood vessels, they should look like they're kind of diving into the foveolae vascular zone. And if you're not familiar with OCTA, this isn't going to make a whole bunch of sense, but hopefully you can at least appreciate how these blood vessels look like they're kind of diving in there. And this is the deep plexus. So we're going a little bit further down now, a little bit farther into the neurosensory retina. Look at the anomalous vasculature surrounding the fovea here. So it should look like this all the way around. And you can see that there's this anomalous vasculature there. Okay, I will quickly, I have 10 minutes, quickly go through this last case. This is a patient that had Plaquenil toxicity, and I probably won't be able to go through this in a ton of detail, but 65-year-old Caucasian female who complained of central darkening in her eyes that was getting progressively worse. She had a history of rheumatoid arthritis for 20 plus years. Vision was 20/40 in both eyes. You can see her medications. She was on methotrexate and Plaquenil for 20 years. So what I just wanted to do very briefly in the few minutes that we have left is just talk about Plaquenil toxicity and what the proper workup is of these patients. I would say on OCT Connect, we get a lot of questions on, does anybody think this is Plaquenil toxicity? And I'll preface by saying that you need to have a really high definition, good quality scan, because if you're looking at a scan that's very pixelated, it's very difficult to see toxicity. So just to quickly review, Plaquenil is in the category of medications called DMARDs, or disease-modifying anti-rheumatic drugs. It was initially formulated as an anti-malarial used to treat all kinds of autoimmune diseases. As we know, it's really a very safe drug and used now quite a bit in RA and a lot of dermatologic conditions. If you look at the anatomy of the retina, you ask yourself, why do we get a Bullseye maculopathy with Plaquenil toxicity. And the reason is that Plaquenil likes the RPE. So when it enters into our system, it actually binds to the RPE and pulls on it, like it eats it apart. It likes the taste of it. So when you look at a Bullseye maculopathy and you see the deep pigmented area parafoveally, that's because that is where the Plaquenil binds. It has an affinity for that parafoveal RPE area. So what I wanted, let's just go through this as quickly as we can. But in 2016, and we're due for a revision because it's already 2023, the American Academy of Ophthalmology put out some guidelines on what we should do to monitor patients, or what should the workup be for patients that are on Plaquenil. And really, they found that the two biggest risk factors for patients developing toxicity is the dosage and the duration. So the safe dosage is if patients are taking less than or equal to 5 milligrams per kilogram of their real body weight. And I'm going to show you how to look at that in just a minute. And the second thing is the duration. Obviously, the longer the patient's on the medication, the bigger the risk of developing toxicity is going to be. If you look at a patient that's only been on it for up to 5 years, the risk of toxicity is actually less than 1%. And that number goes up to 20% after 20 years. So again, remember to always look at dose and to look at duration. I'm going to skip through these charts for purposes of time. Other things that are important to look at are other risk factors like their renal filtration rate. If they can't clear medications out of their bodies, they're going to be at a greater risk for toxicity. Looking at other drugs that might cause maculopathy like tamoxifen. The recommendation for screening is when they start the medication, and then really depending on the risk factors and the patient profile, you can make the decision. I like to see these patients every year, but the actual academy says you can do it at the time of that they start the medication, then 5 years after, assuming that they don't have any significant, risk factors. Let's look at how we would approach a patient. This is what I wanted to get to. So Mr. Jones walks in and he says to you, I'm on Plaquenil. Okay. Does that mean that we're going to treat Mr. Jones the same way? He might weigh 700 pounds, let's say 175 pounds, or Mrs. Jones, who weighs 120 pounds. Are we going to assess these patients the same way? No. Okay. So the first thing you want to do is you want to evaluate the dosage. So you want to ask the patient, what is your weight? If you don't have a scale, if it's a woman, add 20 pounds on to whatever they tell you. That's always my joke, but find out what their weight is, okay? You want to convert their weight into kilograms because we want to get it into this fashion, milligrams per kilogram. So let's take an example of a patient that weighs 150 pounds. We ask Siri, how many kilograms is 150 pounds? That converts to 68 kilograms. The patient tells you they're taking 200 milligrams BID, which is the recommended dose. So that comes out to 400 milligrams. So if you do the conversion, 400 milligrams divided by 68 kilograms comes out to 5.88 milligrams per kilogram. So what you want to keep in mind here is that a patient that's lighter shouldn't be or is not okay taking the same amount of medication as a patient that's heavier because their body can't tolerate the same amount of medication. So it's super important that you don't just say, oh, the patient's taking 400 milligrams, they're fine. That's what the FDA approves. Make sure that you're doing the conversion and make sure they're under 5 milligrams per kilogram. If they're not, they're at an increased risk of developing toxicity. And remember to look at the duration or to ask them how many years they've been on the medication. So I want to show you kind of this patient that I presented. So this was the patient that I told you at the beginning of this case. You can see it's a Bullseye maculopathy. You can see the area of parafoveal depigmentation, which is the area where that hydroxychloroquine or Plaquenil bound to the RPE and kind of ate away at it. Okay. And we're going to get to the OCT in just a minute. 10-2 visual field is probably going to show you dense scotomas centrally. In Asians, we recommend doing 24-2s because sometimes the defects are a little further out from the actual fovea, but in our Caucasian patients and our African-American patients, 10-2 is what's recommended. So OCT, this is normal OCT. This is typical Bullseye maculopathy, secondary to Plaquenil toxicity. So what happens is, here's our neurosensory retina, looks fairly normal. If you look very closely at where these black arrows are pointing, what you're going to notice is that there is attenuation or loss of the photoreceptors all over here and all over here. This is actually normal in the center here. This is the photoreceptor integrity line. This is where the cones are densely packed. So what happens is because there's loss of the PIL here and here, the neurosensory retina sinks down into those kind of cavitations, causing what we call a flying saucer sign. So that forms because the sensory retina is kind of filling up the space where the photoreceptors are gone. And this correlates with that depigmented area, making it the bullseye maculopathy appearance. So this is just another really pretty example of healthy in the fovea here. This patient's going to be 20/20, but look at the parafoveal area. You can see that the photoreceptors are missing here and missing here, and they're still living here. So these are the really, really subtle changes that you're going to see in patients that have Plaquenil toxicity. And you can see the flying saucer sign here because the cavitation or the substance of the outer retina, it's sinking down into the area where the photoreceptors are missing. You can see here that you really do need a very high quality scan to see this. Going back to our patient, why was the vision 20/40? Because in my patient, the actual area is starting to affect the fovea as well. You'll notice that the photoreceptors are missing all throughout here versus this patient that had a healthy PIL at the fovea. My patient did not. You can see that there's loss of tissue all through the fovea here and all through the fovea here.